Hi, everyone. Thanks for joining. I'm going to go ahead and get started as it is 11:30 here in Chicago, and we do have a lot of content to get through. I did want to highlight for everyone that this virtual town hall is being recorded so that your comments and input may be accurately captured and used to support AAPM&R advocacy and awareness efforts regarding the physician fee schedule. So welcome to the AAPM&R Town Hall on the Medicare Physician Fee Schedule Proposed Rule, Evaluation and Management Proposals. My name is Carolyn Winter Rosenberg, and I'm the Manager of Reimbursement and Regulatory Affairs here at the Academy. I'll be your facilitator for today's session. I'm joined by two experts from Heart Health Strategies. Bob Jasek is the Vice President of Coverage and Payment Policy for Heart Health, and Cindy Moon is the Vice President of Healthcare Payment and Delivery Reform for Heart Health. The three of us are here to tell you as much as we can about the Medicare Physician Fee Schedule proposed rule, as well as obtaining your feedback on the proposed policies. Throughout the presentation, we will be asking for your feedback. On this slide, you can see two different ways to participate in the town hall. The first is to raise your hand using the raise your hand feature, as you can see on the screen up here. That's going to indicate to us that you want to have your line unmuted, and you'll be able to speak to the full group. You can also use the questions feature to provide us additional input. And as available, we will read those questions aloud on the webinar to include that feedback in this session. If you would like to send us some additional feedback following the session, we will have our email available on the last slide of this presentation. So getting started, we do have a lot to get through today, and we want to give you as much time as possible to give your feedback. By way of background, I wanted to explain, and this may be repetitive for many of you, CMS publishes the Medicare Physician Fee Schedule on an annual basis. In the summer, usually around July, the proposed rule is released, and that proposes payment and policy changes for the following year. So this July, we received a rule that proposes payment and policy changes that will take effect January 2019. The proposals, based on comment, are finalized in late October or early November, and then, like I said, they take effect January 1 the following year. This year, the rule includes a number of proposed changes to evaluation and management, or E&M services, specific to office and outpatient E&M. CMS highlights that E&M services, all E&M services, account for 40% of allowed charges for physician fee schedule services. Further, office and outpatient E&M visits, which are the subject of this rule, those visits account for 20% of the allowed charges, so half of that 40%. These percentages emphasize why CMS is looking at evaluation and management services as they're looking to kind of refine payment. Finally, I'll note that E&M services have been, CMS has been looking at E&M services for some time. They were specifically called out in the 2018 proposed rule, which was released in July of 2017. And we did provide some feedback to CMS at that time. So on this slide is a quote from our AAPM&R comment letter, which we submitted in September of 2017 as a comment to that proposed rule. We gave a very succinct comment on E&M documentation guidelines in this comment letter. We noted that the E&M guidelines as they exist, the current 95 and 97 guidelines, do create administrative burden for physicians. we did also note that those guidelines were the product of a broad multi-specialty effort, and that we believe any effort to revise the current guidelines should include similar cross-specialty physician stakeholder participation. And this was to ensure that the revised guidelines would be relevant to all specialties. So essentially what we were saying in that comment was, if you're going to revise these guidelines, we want to be a part of it. We want to participate. We want to voice in how the guidelines are revised. That was our comment to CMS. So there are several proposals in the rule that we're going to talk through today. I've noted on this slide, these proposed policies are for office and outpatient E&M only. So we are not talking about E&M that is done in the SNF setting. We're not talking about E&M that's done in the hospital setting. We are just talking about office and outpatient E&M. So these are the five issues that we're going to be talking through and asking for your feedback on. The first is reducing burden related to E&M visit documentation. Then we're going to talk about collapsing of payment for level 2 through 5 visits. This is something that we've been promoting significantly as we try to get people on this call to give their feedback. Then we're going to briefly discuss the new codes for all podiatry E&M visits and what example that may be setting for future directions that CMS wants to take. Then we're going to go through 3 add-on codes that CMS is proposing to create, which will capture some additional elements of E&M with the intention of expanding payment, building on payment for services sort of above and beyond the standard E&M. And then finally, Bob Jasek is going to give us a summary of the payment reduction proposed when E&M visits are billed with other services on the same day. Before we jump into those 5 points, I wanted to highlight for you that CMS has projected what the impact of these changes will be on different specialties. For physiatry, CMS estimated the impact of the proposals would be minimal in the area of 1%. However, the American Medical Association conducted their own analysis, and they have found that there would be a negative 5% impact on payment for physical medicine office visits. So I think realistically, that is an estimate that we should consider when we're developing our comments for the rule. So the first major proposal outlined in the rule is a proposal to decrease documentation burden. For office, outpatient, and E&M visits, CMS proposes that the provider, starting January 1, would be able to choose one of 3 ways to document a service. Providers could, excuse me. Providers could bill using, the current 95 or 97 guidelines, so basically just continuing to bill the same way that you do. You could switch to billing exclusively based on time. This is not the same type of time-based billing that is currently used, where the visit has to include 50% of the time face-to-face with the patient spent on counseling or coordination of care. This new time-based billing would just be based on the total time of the visit. The third method would be just documenting medical decision-making. And providers must always document medical necessity. So they are stipulating medical necessity will continue to need to be documented. So in addition to these changes, CMS is recommending that for visit levels 2 through 5, there would just be a minimum documentation standard. CMS would require practitioners to only meet documentation requirements associated with level 2 visit requirements, unless they're using time-based billing. And this would be regardless of the visit level that they bill. So if you were billing a level 4 visit, you would still only need to meet the requirements for level 2. CMS does acknowledge in the context of the rule that there could be other reasons to document beyond level 2, but that for the purposes of Medicare requirements, that minimum documentation would be the only thing necessary. The other point that CMS outlines is that for history and exams, so for example, if you're still billing the 97 or 95 guidelines, your documentation can focus on what has changed since the last visit or pertinent items that have not changed. So they're essentially decreasing those history and exam requirements to be just the pertinent factors. There are several aspects of this proposed documentation policy which aren't completely clear, and we've tried to get some clarification and we'll continue to seek clarification. For example, if a provider chooses to bill based on time, CMS has not yet established a minimum amount of time for the visit. They're actually seeking our input on that. Additionally, it's not clear whether or not private payers will also adopt these new requirements, which may mean that providers will need to change how they document based on the patient's insurance. Furthermore, it's not clear how quickly EHR vendors will be able to modify their existing documentation templates to meet these new requirements. And finally, there are potential medical legal ramifications of decreasing documentation. So I know that that was a lot of information, but at this point, we're going to ask that if you have comments or questions related to the documentation changes, please either raise your hand or use the question feature to give us a question or a comment. So I do see that someone's raised their hand. Give me 1 second. I'm not seeing a hand raised. Oh, there we go. Dr. Walshin, we're going to unmute your line right now, so you can go ahead and speak to us now. Dr. Walshin, can you hear us? Okay, Dr. Walshin, I'm going to ask you to go ahead and enter your question into the question box because we aren't hearing you. Do we have any questions? Extra time payable. Time. So we had a question about extra time pay being $9. I am guessing that that is related to some of the add-on codes that CMS is proposing, which we are going to talk about in a few slides. So I'll hold off on answering that unless you want to clarify that question. And then the next question is, what are the proposed fees when based on time and or old guidelines? And we're going to talk about payment in the next slides. I will say, though, that the payment does not change based on which documentation method you're going to choose. So were you to choose to document based on the old guidelines, your payment will be the exact same as if you were to choose to document solely that time element. I'll show you those payment rates in just a second. So we had a question that is a very good one. I understand this time CMS is proposing changes to outpatient E&M only. once this is done, is inpatient E&M going to be next? I think that's an excellent question, and I think we're very concerned that that is the case. CMS does indicate in the rule that they are looking at outpatient and office visits first, and that they recognize that that E&M in general is not looking the way they want it to look, that the codes are not meeting the needs that they think specialties have. So if I were to sort of divine what the next couple years will bring, I think if we don't sort of get this figured out for office and outpatient visits, these types of changes are likely to be seen in other settings, absolutely. Medical legal ramifications is my concern. Still need to document for medical necessity and in case we ever go to court. I absolutely recognize that point, and that's one that we have heard from other specialties are hearing that from their members as well. So I think that that is definitely going to be something that we're considering as we put together our comments. We'll take a couple more questions. Dr. Walshin, let me see if I can unmute you, and if you have a question, we can get back. Hang on one second. All right, Dr. Walshin, your line is unmuted. If you have a question, go ahead now.
Can you hear me?
We can hear you. Great, thank you.
Yeah, this time thing, I mean, I'm glad we had this webinar. The time thing is just utter nonsense. And one point I want to make is what they've done is they've lowered the bar and they want us to come back, but not back to where we were. The problem is the bar was never raised high enough as far as the time that it takes to go through documentation to do a physiatric exam in general. So I would hope that in our response to this, we're not just going back to where the bar was, but it's higher, and we raised the bar because it wasn't acceptable where it is. A case in point, I saw a patient Monday that was seen by the primary care doctor who referred, and the neurologist had an EMG which was normal, and he had a complaint of foot drop for 2 years. So everybody says, oh, he has foot drop, but I did a thorough exam that took 2 hours, sitting, standing, supine, prone, walking. He has painless weakness, so my working diagnosis is ALS, similar to a patient I had 15 years ago. So now I need to go through all the tests and eventually, hopefully, rule it out. But the bottom line is I took 2 hours to do that because I'm thorough. A lot of physiatrists do a thorough exam. So for CMS to say it's minimal impact is just utter nonsense. I mean, you can't put a time frame on it. I also treat people with pain that end up not needing medications because their pain is just physical and emotional pains from just years of just life. So the bottom line is you can't put a stopwatch on it. And the problem I have with just having these codes and then these extra codes for extra information, that's nonsense too, because that's just going to be more layers of time and documentation to prove what we do. The only thing I can say as far as less documentation, which may be helpful, is the whole review of systems things. Having to go through all the systems and pertinent positive and negatives, a lot of it's a waste of time. There are times where, yes, putting in a pertinent positive and negative can be helpful, but that's up to the discretion of the doctors. And also, as far as you say legally, for a lot of us that deal with legal things, that doesn't decrease your need for documentation.
Excellent. Thank you. Thank you. We really appreciate that feedback. And just so all of you know, we may reach out to you individually just based on your comments for more information. So we really appreciate your feedback. So just in the interest of time, I am going to move on to our next topic because I think we will have much more in the way of comments. But if you have more comments related to documentation, you can feel free to continue to enter those. And if we have time at the end, we can revisit those. So The next section we'll be reviewing is related to payment for office and outpatient E&M visits. In the proposed rule, CMS notes that it believes the existing office and outpatient E&M codes do not reflect the full range of services provided by various specialties. Further, CMS suggests that it is burdensome for the physician to select an audit visit level. So therefore, based on those two arguments, CMS has proposed to collapse payment for E&M services levels 2 through 5 into a single payment rate. This payment rate is between the current payment rate for level 3 and 4 visits. So just to give you kind of what this looks like in the numbers, on this slide, we've got the current work RVU for 2018 and the current payment rates for 2018 for new patient office visits. Under this proposal, CMS is retaining the RVU and rate independent for new patient level 1 visit, but for levels 2 through 5, CMS is collapsing these RVUs into an RVU of 1.9, which sits between 99203 and 99204. Likewise, the estimated payment is then between those two old payment rates as well. So you are seeing that, for example, providers who are billing more typically level 4 and 5 visits will see less payment. Providers who are billing more typically level 2 and 3 visits will see more payment. This is mirrored on for established patient work RVUs and payments. So you're seeing a 1.22 RVU proposed for 2019 for level 2 through 5 and $93 estimated in payment for levels 2 through 5. So for this, I'm going to move on to comments and questions pretty much immediately. I can move back to those previous slides if you'd like. Maybe I'll just leave the new patient rates up to kind of for you to take that in, and we'll go to questions immediately. We've got it. Look, hand raised. Just 1 second. So Dr. Abraham, I am going to unmute your line. Your line is unmuted.
Hi, can you hear me?
We can hear you. Go ahead. Okay,
so I think I was one of the few people that commented on Phys Forum regarding the new CMS proposal, and I know that you know, I did get a response back from Carolyn, and I really appreciate that. You know, as my comments in Phys Forum, this is absolutely outrageous. I mean, you know, what this is going to result in so many problems. And the biggest thing is that it's going to be a problematic for the Medicare patients, because basically what it's going to do is it's going to de-incentivize any physician from spending any amount of time with the patient. Why should we as physicians spend more time when we're not going to get paid for that time? It's nonsensical, it's illogical. So just like anybody else, if you're not going to get paid for your time, you're not going to spend the time. So, I mean, what this is going to do is this is going to force physicians to spend the minimum amount of time for Medicare patients, and the quality of the care is going to go down, and that's going to affect everyone. And for CMS to say that it's going to have a minimal effect on physiatry is absolutely outrageous. I mean, we are one of the specialties, like the other physician was saying, that we deal with very complex patients, and these patients require time to provide adequate and responsible care. And if we're not going to get paid for that time, then why should we even see the patients? What this is going to result in is less people taking Medicare. Medicare patients will have less choice on where to go, and they'll receive less quality care. The other thing is that physicians like myself who are in solo practice, this is going to have a huge impact on us. I see about 35 to 45% of my practice is out, Medicare. And for them to say it's even going to have a 1 to 5% increase, this is going to have like a 50% reduction of payment for me. And it's going to be so bad that a lot of private practices will be forced to close their doors. So to me, this is just an outrageous, outrageous proposal. And I really believe that we have to fight this with everything that we have. This is just unacceptable. And I know that there's other specialties that are banding together, and all, I know that PM&R has joined with the American Academy of Neurology, and I commend that collaboration. But I really think that this is a proposal that needs to be fought, because this is absolutely outrageous.
Thank you so much, Dr. Abraham. I'm going to go ahead and remute your line, but feel free to raise your hand if you'd like to speak again. I'm going to switch ahead to the established patient codes, just so you have those in front of you as well. We have a couple comments that I'm simply going to read because I think they're important for everyone to hear. Not necessarily questions, but kind of comments that are echoing Dr. Abraham. More often than not, our patients are complex. This payment watering down does not recognize what a specialist such as ourselves do. CMS needs to be educated that physiatrists are not primary care doctors, though our brethren should be better paid as well. Putting a specialty such as PM&R in the same bucket is outrageous. So thank you for that comment. Another comment from another member: really, it hurts the most involved patients. We'll need to have recurrent follow-up for patients with mobility issues and difficulties with transportation and financial difficulties. Another good point, thank you. I'm also solo practice, and I'm considering moving to cash-only practice and no longer taking Medicare patients. This is sad, as I'm the only PM&R doctor for hundreds of miles. It's an important point in terms of access. Another point, academic institutions will really be hurt. They cannot stop taking Medicare. Excellent point. And this will hurt the disabled population because they won't have physicians to see. So thank you for all of those comments. And another point, which several other societies are making as well, physicians will make up the difference on volume, decreasing the time they spend with Medicare patients. Practice patterns and changes that we estimate physicians to make based on this, this proposal is definitely something that we'll want to consider when we put together our comments for CMS. Sort of estimating what this change will do to a given practice is very important. So again, feel free to send any additional questions or comments. At this point, I am going to move on to our next issue, which is related to podiatry visits. And a major change in payment for podiatry care. In the proposed rule, CMS explains that podiatrists were found to bill lower level E&M services than other specialties. So therefore, instead of receiving that new payment rate that we just looked at, the sort of combination rate that sits between levels 3 and 4, CMS is proposing that podiatry will bill a new G code valued between current E&M levels 2 and 3, so a lower reimbursed code. There are going to be 2 new G codes for podiatry. One will be for new patients and one for established patients. So they really just have that one code to bill for each type of patient. And the reason that we're bringing this to your attention is that it's the first time a specialty has been singled out for a specialty-specific office visit code. Traditionally, specialties just use E&M. Every specialty uses E&M. So this really begs the question, will CMS do this for other specialties? We have heard that podiatry is not looking favorably upon this. They haven't finalized their comments yet, but this is not something that they are excited about. But we wanted to get Academy member feedback on whether or not they're concerned about the shift towards singling out certain specialties for different types of payment related to office visits. And this may be something that you kind of want to think about a little bit more, and you can feel free to email us after. But we have one hand raised. Let me get to that. Okay. Dr. Saffer, we're going to unmute your line. Oh, Dr. Saffer, it looks like you're self-muted. So if you could unmute. Dr. Saffer, can you hear us? It looks like you're unmuted now. Dr. Saffer, we'll come back to you, but you can also feel free to enter a comment in the question box. We did have another hand raised, Dr. Walshin. I'm unmuting your line now, so you can go ahead and speak.
Yes. Can you hear me?
We can hear you. Thanks.
Yes. Yeah. I don't want to belittle podiatry because they're valuable too, but you know, if somebody comes and they have a foot problem, they're still not going to just put their blinders on or blinkers and assume it's the foot is the problem. They still have to see if there's anything. Is it the back? Is it the hip, etc.? But I'm just hypothesizing one of the reasons they may bill lower is because they only are targeting one area of the body. The other thing I found, and it hurts doctors in general, when CMS and all these insurers look at the codes that doctors bill, is I find orthopedists and things like that tend to bill lower E&M visits because they're only concerned about just getting the patient in, because they're also going to make a lot more money on procedures, and that hurts doctors that rely on E&M codes and are not just doing it to make money, but they're also just more thorough, and that's the only way that they do make money. So there's no incentive for them to have to cut corners.
Thank you. Thanks for that point. We had a couple of other comments related to this issue. One member definitely concerned because this sets a dangerous precedent, and another member who thinks that this is clearly a step to do the same thing to other specialties in the future. So we appreciate that feedback. And Dr. Saffer, I think you're still unmuted on our end if you want to try. Dr. Saffer, we'll have you enter comments in the question box if you have one. We had one more comment come through. CMS barely knows what a physiatrist is when I speak with them. Having podiatrists as the example specialty for payment changes is going to make discussions with them about physiatry additionally challenging. I think that's a very fair point. This is a point that is actually important, that CMS, even at higher admin levels, do not know what physiatry is. We need to thoroughly educate them about what we are and what we do, as in my mind, we are a very unique specialty because we are so comprehensive. Perhaps our payment model should be completely different. I think that's a very good point. And definitely informing CMS about physiatry is one of our internal priorities. So we appreciate that point, absolutely. In the interest of time, we're going to move on to the next issue. So the next issue I'm going to discuss is 3 add-on codes CMS has created to supplement E&M reimbursement. And likewise with all of these policies that I've outlined, these are specifically available for outpatient and office visit E&M. These new add-on codes cannot be billed with other types of E&M. So the first code is for primary care services, and the code is described as visit complexity inherent to evaluation and management associated with primary medical care services that serve as the continuing focal point for all needed healthcare services. As I said, this is an add-on code. It has a very low work RVU associated with it. It's 0.07. And I think the total reimbursement for this one is calculated to be about $5. CMS does, however, estimate that this will be billed with every single primary care focused E&M visit for established patients. So this code is, when CMS did its calculations for this code, it attributed it to primary care providers. But the code itself at this time doesn't include anything that would prohibit a non-primary care provider from billing this if the service they're providing is meeting the descriptor of the code, so being primary medical care services. The second code that I'm highlighting here is for specialty care, and this code is described as visit complexity inherent to evaluation and management associated with endocrinology, rheumatology, hematology oncology, urology, neurology, obstetrics and gynecology, allergy and immunology, otolaryngology, cardiology, or interventional pain management centered care. Again, an add-on code for E&M, office and outpatient services with a slightly higher work RVU of 0.25. I say on this slide that the exact use is still to be clarified. I attended a listening session with CMS about a week and a half ago where they were asked several pointed questions about this code. The clarification that we received did not feel to be clarification that we can really stand on. What we were told was that these were not specialties highlighted in this code. They were care areas, so that if the service you provide fits within one of these care areas, you are within rights to bill this code. But similarly to the primary care code, when CMS was doing its calculations for volume of billing associated with this code, they tied the billing to the specialties that are listed within this code. So at this point, I don't want to confidently tell you one way or another that this is a code that we can bill. Obviously, this is a major concern to us because physiatry is not listed here. And obviously, when you're talking about visit complexity, physiatry should be listed as our members do very complex services. So this will certainly be something that we comment on, and we definitely want your feedback on how to formulate that comment. The third add-on code that I wanted to highlight for you is a prolonged service code. So this code is described as prolonged evaluation, management, or psychotherapy service beyond the typical service time of the primary procedure in the office or other outpatient setting requiring direct patient contact beyond the usual service. And it's estimated to be at 30 minutes as the starting point. So this code depends, we're kind of depending on a couple of things tied to this code. We need to find out what that typical time of the primary procedure, the primary E&M, is set to be, and CMS has not really established that typical service time yet. But the nice thing about this code is that the current prolonged services codes can only be billed once an additional hour of service time is provided. So this gives us that 30-minute window. So if your time exceeds by only 35 minutes, you currently wouldn't be able to bill prolonged services, but with this new code, you would. So at this point, we'll take comments and questions related to those 3 add-on codes. I know I moved very quickly through those, so I think what I'm going to do is leave the descriptor for the specialty care code up, just so you have something to kind of look at to maybe prompt some comments. Dr. Saffer, I'm going to unmute you now, and we'll see if this works.
Can you hear me? Hello?
We can hear you. Thank you.
Yeah, the problem before was I was on the webinar, but I also dialed in on the phone number.
Okay.
Because I'm sitting in there, I use a Bluetooth, one of those headpieces. So anyway, so I for whatever reason, when you tried to unlock me before, it wasn't going through the phone. I can kind of put together the 2 points. I mean, I think obviously this is very key. I think the idea of having something that's specific to a specialty with regards to the podiatry is key as an important area. I wanted to talk about the fact when Medicare got rid of consult codes and then also defined the difference between a new patient and an old patient as a 3-year rule. I think those are crucial things that should be part of the discussion. When I tell my staff about doing an intake questionnaire on somebody, I said, look, if this is a 20-year-old, I said, I don't need them to fill out a whole new review of systems questionnaire, if we've seen them, in the last year or 2. I said, because there's probably not a lot different. I can ask them fairly quickly and they'll say yes or no. I said, on the other hand, I said, if you've got somebody who's in the Medicare population, you're going to have somebody who may have had a lot happen in 6 months. And if you haven't seen them, it could be a very detailed review because a lot of stuff may have happened. But unfortunately, with that definition of new patient, new problem, everything under 3 years becomes a follow-up. And now if you look at what these follow-up codes are doing, you're really screwed because it's downplaying the complexity even there. So I think the awareness and reinforcement of how that's a problem, that they've already left in place, that will be compounded by this new move is important to mention. And we've felt this battle as well with the private payers. A lot of them have had discussions about dropping consult codes. And again, if you have a complex issue or a complex patient, somebody wants to do a consult and then that option's not available. And again, if they're using the same 3-year rule, you could be, it could be a big problem.
Great. Yeah, agreed. Thank you. Thank you. Before we go back to the phone, there were a couple questions that came through that show sort of a gap in my slides, which is the issue of the rate for the new prolonged service code. And I do not actually have that handy. Bob or Cindy, do either of you have that the prolonged service code RVU and approximate rate, as well as what the translation to payment rate is for the specialty add-on code?
Hi, this is Bob. I actually pulled that up just in case it came up. So the prolonged services code has a proposed work RVU rate of 1.17. I don't know what the full RVUs will be, but that would put it over about $40 at the very least. And then on the payment rate for the specialty add-on code, I believe it comes out to roughly $14.
Great, thank you. Just going back to the phone, we do have Dr. Walshin. I'm going to unmute your line right now. So you can go ahead and whenever you're ready. We can hear you.
I just want to say hi to Mike, colleague, and also CMS's love affair with primary care has to end, and that needs to, because basically one of my complaints has been I do a lot of nursing home work, so I see a lot of Medicare and Medicaid people. We never got the respect of the primary care doctors with the Affordable Care Act this bump, at least federally and within Connecticut, of getting paid twice as much for Medicaid as primary care doctors do, who now see Medicaid people, but we don't. But the point is that for some people, and for many patients, we are their primary care doctor because of the complexities what we deal with. So this differentiation between primary care and specialties is not really applicable to a lot of the people that we see. So that mindset has to change. What Michael said is true. I cringe at a new patient. I saw a patient recently in a nursing home. I hadn't seen him for 2 years and 11 3/4 months. So technically I had to be honest and bill a follow-up. Did I do everything that a new patient was? Sure as I did. So if I see a patient like that in the office, it's the same thing. So as Mike says, absolutely. The time thing. The biggest thing that needs to happen is the whole coding book needs to be trashed, burned. Okay, it's old. It should have gone out with disco. It's not applicable to what we see now. And we're basically imprisoned by this coding book that AMA makes a fortune over. That has to be scrapped too. This isn't just the level of coding. It's the time, it's everything. That's a major problem. And if we do go to value, unfortunately, when other people are determining the value of what we do, doctors and patients are going to lose.
Thank you both for your comments on this. Very much appreciated. We did have a question that I can't really answer, but I'm going to read it anyway, and we can hopefully get an answer for this person. So the point was regarding the consult codes and the elimination of the consult codes being highly problematic. How did this happen, and what is the Academy doing to reestablish this? Unfortunately, this issue really predates my time working in this field in general. So I can't speak to that, but we have your name, so we can get back to you on that, hopefully in the next week or so. It looks like we do have one more hand raised. Dr. Saffer, I think your line is actually still unmuted.
Oh, okay. I hope there wasn't any background noise there. That the consult code is water under the bridge. The question. Excuse me a second. I've just got to turn this off. The consult code is water under the bridge. I mean, I think that if they change the new patient rule, that would be a reasonable option, so that you could at least see somebody new. But it's been in place for a long time. As you said, it predated the amount of time you've been here working on it, on coding. So I don't think that that's going to change. In fact, the big battle is that payers are, private payers are looking at doing the same thing, and we've so far argued against that. And I don't know what the best argument would be for it. Obviously, we argue that, younger people have a new injury, and the primary care doc, sees them and wants to get a consult. So that's a reasonable approach. Maybe with the older population, if you've already seen somebody, it's going to be like you're taking care of them now for the rest of their life. And as long as it's been, 3 years, it's not going to be a new patient. And I think that should change a little bit. But I don't think you're going to get Medicare to change that particular part of the rule. That's my gut feeling.
Sure. Okay, much appreciated. Thank you. I'm gonna go ahead and remute your line, but again, feel free to raise your hand. So I'm gonna move on to our next issue. This is, I'm actually going to introduce Bob Jasek, who's going to speak about the proposed payment reduction with when E&M is billed with a procedure. Bob, there is a second slide, so when you're ready for me to advance, just let me know, and I'll advance the slide, okay?
Great, thank you. Just in terms of the pre-existing policy, before we get into the contours of this proposal, some of you might be familiar with what Medicare refers to as the MPPR, which is the multiple procedure payment reduction. And there are a couple different versions of it. They have it for imaging, they have it for therapy services, and in those instances, we're talking about PE and the professional component. But they also have the MPPR for procedures. And what happens under that policy is that if you have multiple procedures that are billed on the same day, Medicare will pay 100% of the highest valued service, and then every subsequent service to that on the same day gets a reduction of 50%, and that's across the whole payment for that procedure, not just PE or professional component. And so here, what they're proposing, which was confusing in the rule, but we've since gotten clarification, is that they're proposing to add all of those new and established E&M codes, including the collapsed payment levels, to that list. So if you were to bill an E&M on the same day with another service, and conceivably my guess would be you would use modifier 25 to protect that E&M so that you could get paid for it, that E&M would then, under this policy, now be subject to that 50% reduction. And Carolyn, then on the next slide, we can take a look at some of the services. Here, what was pulled together were just some of the procedures that are already on that MPPR list. So if you were, for example, to bill an E&M on the same day with any of the procedures or code ranges that you see here, that E&M would be subject to a 50% reduction. So in addition to that code collapse, if there's an E&M that goes with it, along with one of these procedures, there would be an additional reduction to that E&M. I'm happy to take questions on that too.
Thanks, Bob. So we have a Dr. Saffer. I'm going to unmute your line. Trying to. Okay. It looks like you're unmuted. Yep. There you go. You're all set.
Thanks. So actually, I'm kind of curious. I mean, I know this is something that we've battled with Anthem Blue Cross on a national level, and they kind of walked it back a little bit. I think they started at 50%, and I think they walked it back to 25%. Is this the same type of thing? And I'm wondering whether somehow they were kind of aware of where this was going on the Medicare level, or am I missing a detail? Is it different? Are you familiar with the issues with Anthem?
Yes, and your assessment is one that I would say is accurate, that it's definitely similar in structure, and that there are questions about whether one of the reasons that they slowed down on pushing their policy was because they knew this was coming.
Interesting. Thank you.
Yep. The one other thing that I would add is oh, sorry.
No, go ahead. Yeah, go ahead.
One of the things that I would add is that there's been a lot of conversation about sort of the code values and whether a policy like this is appropriate. And and so what a lot of people are advocating is that if you believe that there's overlap, you need to do this on a code-by-code basis, because for some codes where they are performed typically on the same day as an E&M, the value for that E&M has already been pulled out of the procedure code, and so this would be a double hit. So there's concern that they're taking out a cut on something where the duplication was already removed.
Great. I think that kind of speaks to some of our first questions that have come through, which are kind of looking for what CMS's rationale is for reducing payment, given, that there really isn't much duplication. So is there anything else that you want to add to that?
No, I think, yeah, that's exactly what CMS's theory is that you have duplication here, and so the focus of critiquing this would have to be on why that assumption is incorrect. And like I said, a lot of the codes have already had that duplication removed.
One comment came through highlighting that if there's one thing that we really need to fight, this is this would be the one thing to strategize on. All outpatient PM&R physicians do many procedures in the outpatient setting. I would say that, when Dr. Saffer made the connection to the Anthem policies, that's kind of right on in the direction that we're looking at opposition to this, with support of a number of other organizations, which we partnered with for when we protested the Anthem change, including the American Medical Association, who does who recommends values of these codes to CMS. When the AMA does their work, they already take out a fair amount of duplication if a procedure is billed typically with an E&M. So they take out things like greeting the patient and some of the other things that are actually duplicative. So I think with the AMA, we have data to show that duplication has already been removed. Dr. Saffer, I'm going to unmute your line. Okay, you're unmuted now, Dr. Saffer.
Good. It's funny that the webinar, whenever the go-to webinar thing, also, once you tell me you're doing that, it asks me if I want to unmute myself, but it pops up like 3 times. Anyway, I think my comment would be that the part of the battle with Anthem was that, I'm in a big orthopedic group. The answer was, look, people come in, they have a problem, they tell us, that this is going on, and we do an analysis. Oh, you have increased knee pain, you got a little bit of an effusion, it just started last week, you've had no fever. You go through the whole thing, and they say, oh, great, doc, can you give me a shot? And the answer was, well, you're Anthem, so no, you actually have to come back because this whole thing that we just spent in diagnosing you, that gets cut in half, which is what the original proposal was. So the argument was, sure, you can say that you don't need to do that stuff, and we'll just do it at 2 separate appointments. And I'm being a little facetious here because nobody wants to do that, but it's really part of the challenge. It goes back to what you're talking about with the decreased follow-up codes, which is why I was curious to see what those numbers were. If you have a complex patient and you're doing follow-up, you're saying, well, I'm getting underpaid for that. Unless, of course, you say, well, I'll have you come back,
Dr. Saffer, I think we lost you if you're still talking. All right, just in the interest of time, I am going to move to Dr. Walsh, and your line is unmuted now.
Yeah, can you hear me?
We can hear you.
Can you hear me? The other thing is this is trying to pay us. I call it the taxi cab mentality. You get into a cab and you pay that larger amount, and then every eighth of a mile less, as if the last eighth of a mile to get there is less important than getting in the cab. It's just utter nonsense. The other thing is, when you do a procedure, I don't care if it's the day before that you saw this new patient, you really still need to take a brief history, and examine them before you do the procedure, because guess what? Something could have happened in a day. Definitely if the procedure is in a week or two, that brief history exam is still an E&M code, separate from the procedure. And you could keep going on and on where they say, okay, we'll bring them back again. Keep bringing them and bringing them back. But guess what? You still have to examine them. Dr. Saffer does electrodiagnosis. He does intricate invasive injections in the spine. You'd be nuts not to do an exam on somebody each time you do that, regardless of when you saw them before, but you need to get paid for it. So this mentality, even years ago, I think it was, I forget the insurer, they tried to do that with radiology and trauma and saying, okay, if somebody comes into the ER and you're doing 10, 15 x-rays, we'll pay you full amount for the first 3, then we'll decrease the amount we're paying with subsequent x-rays, and maybe won't even pay for the last few. And I don't think that ended up getting passed, but that's the whole mindset. This is really just a form of trying to screw us, part of my language, and just bundle, which is nonsense. We need to be paid for our time for everything we do. And the bottom line is it's still when we code and we document, it's a legal document. So you can't cut corners.
Thank you. I appreciate that. You know, we have a bunch of additional comments here, and we are running up on the end of the hour. So please know that we are saving all of these comments, and I know even some of you have volunteered to help us with advocacy, and we appreciate that so much. So our email address is on the screen right now. So please feel free to email us with any additional comments. We are sending out a survey. It should go out in the Connection newsletter today. I actually believe it may have already gone out. And in the survey, we're asking you to share how your patients and how your practice pattern will be impacted by these policies. So please give us your feedback through the survey or via email, however you feel most comfortable. And we did also just get a question about some links in one of our web pages with some issues related to fact sheets. So I will make sure that those fact sheets get updated later today. So if that person could just check back on the website later today, we should have updated links for that. So that concludes our webinar for the day. Sorry we ran a little bit short on time towards the end there, but we really appreciate all your feedback. Just one final thought. Dr. Saffer made an excellent point that we should encourage you to submit your own comments to CMS. And in a follow-up email to the full list of attendees, we'll send you the link to make your own personal comments as well. So thank you, Dr. Saffer. That was an excellent suggestion.